Hello, folks. Welcome to iCubed. This is Dr. Alice Lee. This is iCubed 45. Yeah, iCubed 45. So I have a new guest today. I am particularly excited to have this guest. He is one of what Dr. Kevin Craig says, one of the 4 handsome horsemen that have joined our group in the past couple of years. And in particular, I'm excited because he, along with Dr. Paul Beeston and Dr. Christian Patterson, is from my alma mater, Maricopa Medical Center. So I am excited to welcome Dr. Aaron Johnson to iCubed this month. Hi, Aaron.
Hey, how are you? So good to be on the show.
All right. So why don't you introduce yourself a little bit, Aaron?
Yeah. I grew up in rural part of Idaho. Always wanted to be a doctor growing up. Didn't think I was smart enough for the longest time, but I realized it was a motivation issue rather than an intelligence issue. Once I ended up getting that figured out, I came down here for med school to Arizona, and then lucky enough to match at my top choice, Maricopa County Emergency Medicine Residency. And now I'm 1 year out of residency. Got 1 year of attending under my belt. Still lots left to learn, but hopefully we can at least all learn together.
Right. So Vanderbilt is a tough place to work, and I'm very happy to see that you're still here.
Yeah. Luckily, it seems like I was able to make it through what I refer to as Residency 2.0, where you have 4 elderly, sick, dying patients that you're all managing at the same time, trying to keep everybody alive at the same time.
That is an apt description. So, well, why don't we just go ahead and start the case? So, Aaron, this is a 56-year-old obese male. He comes in to the emergency department with acute onset of severe shortness of breath. We know he's got a history of hypertension, diabetes, and CHF, and atrial fib, okay? He comes in by private vehicle, dropped off, and because he was in such distress, he was brought immediately back to the examination room. There's been no cough, there is no chest pain, but he says he feels like he's drowning. Triage vital signs, room air saturation is 84%. His pulse is at 142, and his blood pressure is 222 over 146. So the respiratory tech puts the patient immediately on the BiPAP once the patient is brought back to the room. The vitals in the room is blood pressure 217 over 183, respirations are 43, heart rate is 113, and the BiPAP is at 100% oxygen with the saturation 77%. On exam, he is pale. He is profusely diaphoretic. He's alert, though. He's talking to me, but he can only speak 1 or 2 words at a time. He's very, very pale looking. And then further on exam, he's got marked neck retractions. He's having heaving respirations. He's got diffuse bilateral coarse bronchi. Okay? He is not feeling any better with the BiPAP. In fact, his stats got worse, right?
Yeah.
Now look at his chart. He's got a history of AFib. He's got non-ischemic cardiomyopathy. He's got CHF, hypertension, diabetes. Quick scan of his meds, amiodarone, carvedilol, clonidine, Eliquis, glipizide, spironolactone. What now?
What now? That's always the important question. So obviously getting hooked up to the monitor, we got IV access, all the This is hooked up on BiPAP already. Getting a little bit worse, it sounds like, on BiPAP. And this is a case that I think is tough. And I think in a couple of years ago, I would have been very, very eager to intubate this patient if he was getting worse on BiPAP.
Right.
It sounds like at the top of the list, most people, including myself, would jump to likely flash pulmonary edema from a CHF exacerbation, him being so hypertensive, him having crackles. But with these patients that are obviously in extremis and getting worse on BiPAP, which you would expect to get a little bit better on BiPAP with flash pulmonary edema, that would give me pause to back up a little bit and think, is there something else going on here besides the obvious diagnosis of a flash pulmonary edema? I'm a huge advocate of bedside ultrasound. I think this would be a great case to grab the point of care probe and do just make sure there's no tamponade, make sure that the pulmonary edema is equal throughout. There might be a popped lung collapse on one side. And in addition to possible abdominal pathology that could be referring symptoms up to the chest cavity. And then something else I would think about too is this could be a pulmonary embolism. And then I would obviously get a portable chest X-ray, labbing him up, do a nitro drip for that really, really profound hypertension.
Right.
Get the aspirin on board, and then really consider some Lasix up front. You don't want to just give Lasix willy-nilly out the gate, but for people that definitely are fluid overloaded, and it sounds like he is fluid overloaded, I guess my big question would be if there's something else going on with him. But probably a little bit of Lasix on board with what appears to be a clinically fluid overloaded scenario would benefit him to help be able to turn around faster and maybe not have to be intubated. It sounds like this guy's probably headed towards intubation, but I don't think we're there yet based on the info available.
That is fantastic, Aaron. Oh my gosh, that is great. Differential is so important. I mean, your explanation of the differentials we really need to consider in the beginning of a very acutely ill patient like this is fantastic that you explained that. So here, I've got an EKG for you. What do you think?
It looks fibby. It looks like he's throwing some yeah, like he's got some definite rate control issues. But yeah, it looks that looks bad.
And so then, very quickly we get the portable chest X-ray, and here it is. What do you think?
Yeah, so that to me looks like ARDS, CHF, fluid overload. That's all pointing us back towards like the heart pathway of based on that chest X-ray. And I think with those X-rays, it's really important to look to see. I mean, obviously we have this confirmation bias of like, oh, that's what I expected to see. That's what's there. I think kind of something that's important to notice what's not there. Like you don't see a popped lung. You don't see signs of really other acute dangerous pathology. You don't see like a big globular heart. So I think it's easy to focus on, things that confirm your working diagnosis, but it's almost more important to focus on things that may detract from your working diagnosis in a patient that's so sick.
That is fantastic, Aaron. So important, especially people like me who've seen so many, patients, and it's very easy for me to jump to a conclusion and then also fall into that confirmation bias,
Well, I've seen that. I know your Gestalt is right 99.9% of the time. First year attending, I feel like I'm starting to get a little bit, I don't want to say cavalier, but I feel like, that's the diagnosis from the door. And then the more I tease it out, the more I realize I'm trying to put a square peg in a round hole.
Well, I think you are making a great point, Aaron, which is that we have to be intentional about avoiding biases. And it's great for me to talk to young ones like you guys because you remind me of that. And I really do believe that more seasoned physicians who have Gestalt still are very tempted or easily fall into their biases, and it's a fine line sometimes between bias and Gestalt, right?
Exactly.
All right. So, Aaron, I'll tell you what I did on this guy because he's extremely sick. I mean, to me, the two things in my mind immediately that were the main problems for him was that he had rapid AFib. All by itself can cause his symptoms, right? But he had pulmonary edema as well, evidence on the chest film and by physical examination. So I wanted to address those two sort of simultaneously or in tandem and just be ginger with what I was doing without overdoing things. So I started the usual, which you started to talk about, right? So, for his rapid AFib, I wanted to give him diltiazem, but not a huge amount because I didn't know for a fact whether his AFib was just simply a reaction to the severity that he was experiencing, severe illness, the pulmonary edema, or was it the cause of his pulmonary edema, right? Kind of a chicken and egg kind of thing question. So I wanted to give him a bolus of diltiazem as opposed to a drip of diltiazem, right? So then the usual includes the nitro drip, which you mentioned. I gave him an alloprolat, which is a common thing done in pulmonary edema.
A huge fan of an alloprolat.
Yeah, exactly. And then IV Lasix, which you mentioned as well. So I ordered that. I gave it a few minutes. This is one of those patients you don't leave the room. You're just standing by the patient and just watching minute to minute and tweaking the management, right?
Right.
So then all those meds I had ordered, giving it a couple of minutes, patient did not get really significantly better. But then, all of a sudden, this little bright light in my head went off. And I don't know if you've ever heard of this or tried this, but I had this thought, push dose nitro. Have you ever heard of push dose nitro?
Yeah, I've listened to a couple of almost podcasts specifically about push dose nitro, and it's crazy how high of doses you give, or I guess what seems like a high dose in compared to what the usual drip is. So
you've never tried it, right?
I feel like I'm still getting my attending legs under me. I usually do a lot of sublingual nitros, which is effectively, honestly, is the same thing. Where if you do 3 sublingual nitros, you're giving somebody 1.2 milligrams of a sublingual nitro. So, I mean, it makes the nursing feel better. I don't have to spend 10 minutes explaining like why it's okay to give these people a milligram of nitroglycerin out the gate, because a lot of times pharmacy, people aren't familiar with it. You just get lost in the weeds sometimes. It's explaining to people why it's okay, but all of a sudden 3 sublingual nitros, like nobody bats an eye at.
Well, I'm glad actually you've not done this before, because I had never done it, and this was a perfect case to try it in my practice, and I am so much a fan now after this, and I'll tell you, and as I go through it, you'll see what I mean. All right. So then everybody knows that every episode of iCubed, I have 2 learning focuses, because you know what? We got too much to learn in every single patient, from every single patient. So on this guy, my first learning focus is push dose nitroglycerin. So alumni 2 has these annual posts on Medscape where he talks about, the 3 best articles for that particular year. And back in 2017, alumni 2 was talking about this particular article. That article was a study. It was a retrospective study of 395 patients, 3 groups. One group was the intermittent nitro bolus group, which is the push dose group. A second group was a continuous nitro infusion group, which is the common thing we all do, right? And then the third group is the combination of nitro infusion plus nitro bolus group. Okay, so the dosage that the patients got in this study was 2 milligram nitro boluses every 3 to 5 minutes. It's a ridiculously high amount of IV nitroglycerin, right? Have you ever heard of that? 2 milligrams at a time?
I've heard of it. I've never seen it. But I think a big point to address too is make sure that you have the right patient to give it to. Like don't try to just force the issue because you read about something. You have to select the right patient to be able to have one person get 2 milligrams of nitroglycerin Q 3 to 5 minutes. I'm reading on the slide.
Perfect.
You gotta be really careful that you are doing the right thing on the right patient. And as long as you're sure about that, like by all means, it sounds like this would be a huge benefit to shortening length of stay and preventing a possible ICU admission.
Yeah, so patient selection is an excellent point, and we'll talk about that later. So then in this particular study, the continuous nitro infusion was just your usual infusions. Like most people will start, around 5-10, and then they may maintain it at 20 to 60 mics per minute, right? Mm-hmm. So the results, without going through all the details, critiquing the methods, the results of this particular study were the following. So the ICU admissions were significantly less in the patients that were bolused with the 2 milligrams of IV nitro. The median length of stay was shorter in those bolus group patients. In terms of intubation and the use of BiPAP were very similar between the groups. In terms of incidence of hypotension or myocardial injury or decreased renal function, it was very similar in all 3 groups. So Amel's point was, the reason I chose this article is because it reaffirms a critically important treatment point in caring for the sickest of sick patients with acute hypertensive heart failure in the emergency department, which is that very high dose nitroglycerin is safe, well tolerated, and effective, but typically underused. Now, In my research, I found this article, which is I just want to bring up because, I'm from Taiwan and this article's from Taiwan, okay? So I'm always proud of them, any studies that come out of there. So this particular article was recent, just a few years ago, and it was a case series of 3 patients. There's anecdotal, of course, but we learned from anecdotes as well. So all 3 of these patients were placed on BiPAP. They all received sublingual nitros, and they all were given 1 milligram nitro boluses every 2 minutes, okay? And these were all acute hypertensive crisis patients. One of the 3 cases was also on a nitro infusion in addition. 2 out of the 3 cases were dialysis patients, actually, and after their treatment with the high-dose nitro boluses and the rest of the treatment, they were actually discharged from the emergency department. And then 1 out of the 3 patients was discharged after a few days being an inpatient. All right. Learning focus number 2. Have you heard of this, Aaron? SCAPE, which is sympathetic crashing acute pulmonary edema.
I've heard the acronym before. I can't say I've read much about it or know much about it.
Oh, good. I didn't ever hear of it, so we can learn together. SCAPE is at the severe end of acute heart failure spectrum. It is a rapid onset syndrome or clinical picture secondary to sympathetic surge. It leads to abrupt increase in arterial tone and flash pulmonary edema. It can lead to rapid deterioration and intubation. These patients are actually often euvolemic. And Lasix doesn't really work in SCAPE very well because of 2 reasons. Number 1, Lasix peaks in 30 minutes to 2 hours, and that's just too long for it to really be effective. And then number 2, patients are often euvolemic, so it's not a matter of the patient needing to get rid of fluid. It's just that the volume and the fluid is in the wrong space in the body. All right. This particular article is a high-dose nitroglycerin infusion for the management of sympathetic crashing acute pulmonary edema, or SCAPE. So this particular article had a case series 4 patients. All of them were started on high-dose continuous nitro infusions. 3 out of the 4 cases were started at 400 micrograms per minute and increased up to 800 micrograms per minute. 1 out of the 4 cases was started a little lower at 200 micrograms per minute. 3 out of the 4 cases were on BiPAP. 1 out of the 4 cases did not actually require BiPAP because the patient improved so rapidly. Going back to Amel's article, he said, and this is, I think, reassuring and kind of gives permission for us to do these high-dose infusions. Amel Batu says, in our practice at the University of Maryland's ED, we have not taken to using the bolus dosing for intravenous nitroglycerin, but instead we consider studies such as this one as validating the safety and efficacy of being aggressive with nitroglycerin in hypertensive patients with acute heart failure. In hypertensive patients with acute heart failure, our typical starting dose of nitroglycerin infusions for these patients is 200 mics per minute with a goal of 400 to 500 mics per minute. So Aaron, in your practice, where do you usually start your nitro drip?
So like I mentioned, I'm a fan of just doing some sublingual nitros, 3 sublingual nitros for people that are really hypertensive, really pulmonary edema. And then I start them at 100, knowing that you can go up quickly because even though it still takes a little bit for nitro to work, even though it is a very, very fast acting medication. If you're sensing some resistance with patient staff and everything, you can start at 100 and then go up to 200 or 300 or 400 within a couple minutes. Ideally, in an ideal world, we would get the nitro drip fast from pharmacy. That's right. For us is a big obstacle. And then 2, make sure that everybody's on board with the plan from the get-go, because nothing worse is you put in something you see in our practice setting, you would go see another very, very, very sick patient. And you would come back and it's not being done. And the nursing staff was just like, well, it seemed too high to me. It doesn't make sense. I'm not familiar with those doses. But then going back to your point that's almost reemphasizes the importance of being comfortable with high push doses, is being able to temporize them until you can get that drip on and started. And I think if you can head it off with the nurses and just being like, look, I know this order seems crazy, but this is definitely the way I want it. Can you stay on pharmacy, make sure it happens, and then do this? Like 99% of the time, I would say they're on board. It's when you put in the order, you're not, and then you have something else you have to deal with. And then that's when the confusion happens. And that's why you have to waste a bunch of time explaining it to them like, yes, this is okay. But if you can get ahead of it and be like, this is the top priority, I really do actually want this the way that it's ordered. And then go on from there and make sure that you're all on the same page.
All right. So we've talked about push dose nitro, and we've talked about high dose infusion, nitro infusions. So I'm sure you are all dying to see and dying to know what happened to my patient, right?
I know I am.
All right, so let's go back. So remember, the patient came in distress. We put him on BiPAP, and it got worse, right? So then about 9 minutes later, his vitals are blood pressure 245 over 158. Heart rate is still 142. Respirations is still high at 47. He's on BiPAP, 100% saturation is up a little bit, 83%. Mm-hmm. And by this point, he had gotten 10 milligrams of IV diltiazem, bolus. He had gotten his enalapril, 1.25. He got into the Lasix. I started him on Nitro Infusion, 5 mics, which is the baby dose. And then with trepidation, I gave him an IV bolus of 200 micrograms. I had the nurse draw up a milligram of nitroglycerin from just the drip bag and put it in a syringe for me. Mm. So I was at the bedside, and I just simply gave the 200 microgram bolus, and all of that was done at this point, like 1940. This is about 10 minutes after he was brought back to the bed. Nothing was really significantly better. So at that point, all right, I increased the nitro drip. I had the nurse do that. I, again, with continued trepidation, gave the patient another bolus of nitro, but this time I was brave, 400 micrograms. And then I gave another diltiazem bolus of 5 milligrams, because he was still really tacky at his with his AFib, right? Mm-hmm. 5 minutes later, blood pressure 206 over 135, 139, heart rate still very fast, AFib. But his respirations were slowing down, 26. He's on the BiPAP still, and his saturations went up, 89%. And at this point I go, okay, I've gotten braver. Let's give one more bolus of 400 mics of nitro. So 15 minutes later, these are his vitals.
Nice. It looks like that guy turned around super, super rapidly. And if my math is correct, I think you gave a total of 1 milligram bolus.
Yes.
So I'm curious, and I'm not, this is Monday morning quarterbacking, and I would have done probably even less aggressive than what you'd have done just because of my comfort level.
Yeah.
I'm curious if you would have gotten the 1 milligram up front, or maybe even 2 milligrams, if you would have gotten better even faster. I mean, obviously, if he got better in 20 minutes, I think you did a pretty darn good job of resuscitating this guy.
I wouldn't have known either, because I really had never done this before. But now that I've researched it, I think if I had given him a milligram right off the bat with his systolic of 240 and a diastolic of 150, he would have just gotten much better, much quicker without crashing. I am sure he would not have crashed at all. And then the rest of his ED course, his blood pressure was 160 over 105, at 8:25, 25 minutes later. And the heart rate's down. His AFib is controlled. His respirations are still continuing to improve with 24. SATs on BiPAP 100% at 98%. And then at the end of my shift that night, we took him off the BiPAP, put him on venti mask, 50% O2, and we avoided intubating him, and we avoided an ICU admission.
Yeah, that's awesome. Good job.
I know. I was like completely converted, 100% converted.
Yeah, so just going through the visualization exercise of if I was in that situation, what would be going through my head? And one thing that I saw on there is his heart rate, despite IV diltiazem, despite nitro, despite enalapril, his heart rate was heading in the wrong direction for a while.
Yes.
So that's something that I know would have given me pause and made me reevaluate. Am I really sure on this diagnosis? And I mean, I applaud you for being able to stick with it, being like, yeah, this is the diagnosis. This is what's happening. We're going to keep going with this push dose pressors. But I just know I would have been really, really nervous to keep going with the treatment if it seemed like his other vital signs were improving, but his heart rate was getting worse despite an AV nodal blocker with the diltiazem. So I'm just curious if that's something that you thought about, or if you just clinically he was improving, so you felt like you were on the right track.
Well, as you know, one set of vitals is just a snapshot, right?
Right.
So even though the heart rate I might have listed on this presentation as 147, but it might have been 135 just 2 seconds before. It's just these vitals are recorded by the nursing. So you are at a disadvantage, or any of these educational case presentations, the victim, that's you, the guest, is at a disadvantage, right? Because you're not actually seeing the patient. So yeah, even though he was still really tachycardic, but his work of breathing was better. I can see that he was not as distressed. I could see that he wasn't so diaphragmatic. He dried up. So the tachycardia didn't worry me as much as the fact that clinically he looked better and his oxygenation was getting better. I think for me, the oxygenation was more important than the tachycardia, right? Because I knew that this was pulmonary edema, just a really severe case of it. And I didn't really, I was very quickly convinced it was that. I mean, there were other differentials, but it was very quick to conclude that accurately that it was just really bad flash pulmonary edema. Mm-hmm. So I think for the one who's listening about the case, you lack that sort of, gut feeling, you lack that actual face-to-face.
Yeah, that makes sense.
Yeah, totally. Well, Aaron, thank you so much for coming. Did you learn something?
Oh, I learned not just something, but lots of something.
That's good. That's fantastic.
Right. And I think it's interesting too, I've read about all these things before, but just how much spaced repetition is important. So I just applaud you for what you're doing with iCubed.
Thank you.
So honestly, like, Amal's a great guy, and he said all this stuff before, but just having that spaced repetition with the different avenue to get it to you with your iCubed, I think is a fantastic thing. So I just thank you for the service that you're doing with that.
All right, folks. Thank you so much for watching me this month and all these multiple months and supporting me. I am so excited that I have yet another alumni for my wonderful residency here as a guest, Dr. Aaron Johnson. And I hope that you guys are still healthy, and I really encourage you to remain vigilant and continue to wear your PPE, please, and keep yourself safe and healthy so that the community you are serving will have you at their side, okay? Well, Aaron, I thank you one more time, and I look forward to working with you. I think tomorrow night we're having night shift together.
Exactly, I'm excited for it. Hopefully there'll be a couple SCAPE patients that we can put this rubber to the road with those patients.
Yes, exactly. Well, bye, folks. See you next month. Bye, Aaron.
All right, thanks, Alice. See you.